It's great to be with you all and to see you virtually. Hopefully we'll be able to see each other in reality soon. Please, I would like you to remind you to stay muted until the end of the talk, and then we will have some time for some questions. Just to give you a little bit of background, so O2M is organizing this webinar series since 1.5 years, I think now. So they are inviting people from academia and industry to cover various aspects of EPR oximetry. So next month, so we will have the pleasure to hear from Ina, I'm not sure how to pronounce the last name, Gerstenstein, who is PhD candidate at University of Chicago, and she is going to speak about oxygen-guided radiation therapy, so comparing EPR and PET in oxygen image. Next month, we will hear from Dr. Bernard Gallez from MD Anderson Cancer Center. And today it's my great pleasure to introduce our today's speaker, Professor Bernard Gallez. I can say that I would not be here without him, as he was my PhD advisor, and at this time I had the best time of my life. So he's a great mentor, but he's also a great scientist, as you can see from his bio. So he got his pharmacy degree in Belgium from University of Louvain. I will not tell you the date, it was some years ago. Then he got his PhD from the same university working on MRI contrast agent. Then he went for a postdoc in Dartmouth, working with Swartz. And we can actually see that we have here 4 generations of researchers, because Bernard did his postdoc with Swartz. I did my PhD with Bernard, and then I have a few of my students here. So it's very, very funny. So his lab is working on mostly on cancer. So developing tools to profile the tumor microenvironment using MRI, EPR, DNP, and then using these tools to improve basically cancer treatment, so improve therapeutic intervention. And today he is going to discuss the role of EPR oximetry to assess pharmacological manipulation of tissue oxygenation. So Bernard, the floor is yours. Let me unshare.
Can you see the slide?
Yeah, we can.
Yeah. This one. Okay, thank you, Benoit, for the kind introduction. So today I was planning first to discuss the effect of pharmacological manipulation of oxygen in most tissue, but I think it's a little bit too large. And even if I will come back to a discussion on most tissue later on, I will mainly focus today on tumor oxygenation. And so what I will do is first to remind, for non-expert, but I believe that most of you are experts, just a few overview on the detrimental consequences of tumor hypoxia, and really the need for oxygen biomarkers to characterize hypoxia, because they will let us to stratify patient with hypoxic tumor. This is a main goal, but also when we plan to make intervention and oxygen manipulation, we need also to be able to monitor the efficiency of the treatment. So we need an oxygen biomarker, and I will make some kind of cartoon view of the different existing oxygen biomarkers, insisting on the niche of EPR oximetry, and especially regarding what we are using with particulate oxygen sensor. And then I will provide you a few examples of illustrative example of pharmacological manipulation, where we will play with the faucet or with the draining plug, and you will see what I mean later on. So let's start with tumor hypoxia and the reason for tumor hypoxia. Actually, when the tumor is growing, there is a need for new vessels, but the new vessels coming from angiogenesis are quite aberrant. You have a chaotic vasculature with blind ends and so on, immature vessel. These immature vessels are leaky, leading to high interstitial fluid pressure, which is a barrier against the circulation. Due to the metabolic pressure and extracellular acidification, you have some increase in the rigidity of the red blood cells with viscous resistance. You have often, due to cancer or due to treatment, anemia, which leads to reduced oxygen transport capacity. Another important consideration is that you have a dynamic evolution of tumor hypoxia with a transient interruption in red cell flux, which is the main cause of fluctuating or cycling hypoxia. And finally, we should not neglect oxygen consumption. Contrarily to the historical dogma, mitochondria are really effective in cancer cells, and even if they are not all using pyruvate, they can use also other substrate like glutamine, for example. And oxygen consumption is also a main factor contributing to the occurrence of tumor hypoxia. So looking to the consequences, the main key player is the hypoxia inducible factor, actually the several hypoxia inducible factors. And when oxygen is present, if alpha is actually hydroxylated on the proline residues, and after ubiquitination, it is degraded by the proteasome. However, if we are in condition of hypoxia, oxygen is not present, the prolyl hydroxylase is not active, and if alpha is translocated to the nucleus, where it dimerizes with if beta, link to DNA and activate the gene transcription of different factor or enzyme that are particularly involved in tumor aggressiveness. This is true for angiogenesis, metastasis, cell proliferation, apoptosis, autophagy, metabolism, tumor immunity. So per se, hypoxia is a problem, but it is also a problem for the response to different cytotoxic treatment, namely irradiation. And as we know all, after irradiation, you have production of free radicals that may damage the DNA. And the radical form on DNA can come back to initial form, except if oxygen is present, where it is, after further reaction, unable to come back to the initial form. And it is known that the radiation dose that is necessary to kill hypoxic cells compared to normoxic cells is about 3 times higher to kill those cells. And when we talk about hypoxia, we need to consider this specific region. If you plot the relative radiation sensitivity as a function of oxygen tension, what you see is that you have a dramatic increase in the radio sensitivity between 0 and 10 millimeter of mercury. And then after 20 millimeter mercury, you go to the plateau. That means that if you want to characterize hypoxia in the specific context of irradiation, we need to be able to tackle and to have an idea of this specific range of PO2, very low PO2. And the consequence of this is that in phase 3 clinical trial, it has been demonstrated that the overall survival, for example, here in terms of response to radiation therapy in head and neck tumor, the overall survival is much better when you have less hypoxic tumor compared to more hypoxic tumor. So, hypoxia is a real problem, and we need to address this problem and to know that hypoxia is present. So we need somehow a kind of oxygen biomarker that could be predictive of the situation. But the convenient use of the predictive biomarker is not only to say that you are in a bad shape, you belong to this category. What we want really to do is to have a solution for those patients. So we can say, yes, we have identified the problem, but we have a solution for you. And that's really, besides the fact that we have oxygen biomarker, we need to have solution. And that's what we are trying to develop. So what could be the solution for overcoming the radiation resistance linked to hypoxia? Of course, we can think about increasing the dose, escalating the dose in hypoxic areas. If we have suitable imaging, we could probably plan a dose redistribution in hypoxic areas. Another possibility is to look to overcoming the radiation resistance at the time of irradiation using an associated treatment. And this is, for example, using sensitizing hypoxic cells or a specific toxin killing hypoxic cells. Another possibility is to think about the transient increase in tumor oxygenation at the time of irradiation, for example, by decreasing oxygen consumption or increasing the oxygen delivery. And this is typically what I will present during this talk. But now we need to think, is this approach of playing on tumor oxygenation really safe? Because if we increase the oxygen in all tissue, can it be a concern in terms of toxicity for the normal tissue? And actually the answer is no, we have not this concern. Why? Because the normal cells are well oxygenated. So if you are here in the normal range and you increase oxygenation, it will not change anything in terms of the radiosensitive status. But actually, if you try to increase the oxygen for those cells that are at very low PO2 and you go over this some kind of threshold, you have a continuous increase up to 10, 20 millimeter of mercury, this will change a lot. You go from the radio resistant cell, as far as oxygen is concerned, of course, to a radio sensitive status. So we need really to think about bridging the gap between tumor hypoxia and radiation practice. And despite the fact that this look for since I would say decades, there are actually no practice in the clinic, at least in the routine. And one really barrier is that we need the possibility to stratify the patient population. And the best example coming from the literature is coming from the so-called Archon protocol. In the Archon protocol, you use accelerated radiation therapy together with carbogen to fight against chronic hypoxia, and nicotinamide that is supposed to fight against acute or cycling hypoxia. And actually, the Archon protocol works very well in preclinical model. It worked well in phase 2 clinical trial, but then when they had the result of a very large phase 3 clinical trial on laryngeal cancer, the results were very disappointing, because actually you see that you have a superimposition of both curves, the one that receive the normal protocol and those that receive the Archon protocol. So there was no benefit in terms of overall survival. But in this same study that was published by this Dutch group, they made a subset of patients where they use biopsies after injection to the patient of pimonidazole. And using this pimonidazole, they looked to some kind of stratification between the hypoxic and normoxic tumor. And actually, in this specific subset of hypoxic tumor, you see that there was really a benefit. Unfortunately, they didn't use any stratification tool in the design of their study. And so this could change really the paradigm. So now we need to think about that we have a good target. It is hypoxia because it's relevant in terms of radiation resistance. But if you want to reach the target, you need to have a very well balanced bow and very well balanced arrow, okay? But this is necessary, but it's not sufficient. Indeed, even if you have identified a good target, and if you have a very well balanced bow and arrow, you may send your arrow in the wrong direction. Or you may not be able to see the dynamic change of the target. You need to remind that hypoxia is really a dynamic stuff evaluating with the time. And also, you need to to have an appropriate administration, even with good arm and good stuff, you may send in the wrong direction and make an inappropriate administration. So we need not only to be able to see that the target area is there, but also to look, if we have a treatment, that we are really hitting this target. So we need a real oxygen dynamic biomarker. And so the question now is, what is the ideal choice for longitudinal studies? And that's, let me go to the discussion about the available oxygen biomarker. And I often use this type of comparison that, let's say that measuring oxygen in a tumor is somehow comparable to measuring temperature in a sauna. Okay, if I ask you to measure the temperature in the sauna, you will say the answer is obvious. You need to use a thermometer. Okay, you put the thermometer in the room. In other words, you need a direct physical method to measure the temperature. And somehow that's what we are doing with direct measurement of oxygen. This is true for oxygen electrode, despite the fact that it's invasive and more commercially available. But this is really the place where EPR oximetry and also some fluoride-19 relaxometry, these are direct measurement based on physical characteristics, directly depending on oxygen presence. Now, another way to estimate the temperature in the sauna is to look to the temperature in the circulating water in the ether. And somehow this is what we are doing if we apply bold MRI. We are looking to the saturation of oxygen in the circulation. Okay, so this is interesting, but what we are measuring is in the circulation. And also we have absolutely no idea of if the door is open. In other words, the calories could simply be consumed because you have opened the door. So you are looking only to the temperature here in the circulating water, the oxygen in the circulation. Another way is to measure the flow in the circulating water in the ether. Somehow this is what we apply if we are measuring the blood flow using dynamic contrast enhanced MRI or dynamic contrast enhanced CT. Okay, again, we have only an idea on the flow. This could be interesting if we want to measure the flow and if we are manipulating the flow. Okay, but the final aim, are we changing the temperature in the sauna? We have no idea. And finally, you may look to what happens in the sauna. If you have several naked people in the room, actually, you don't know the temperature inside the sauna, but you may think that it's slightly hot inside, okay? And so this is the comparison with nitro-imidazole using PET, for example. They accumulate generally in hypoxic areas, but you have no idea about the real temperature that is present. And so this led us to go to EPR oximetry, and especially what we are using is a solid oxygen sensor, where actually we are using a sensor which are extremely sensitive to the presence of oxygen in the environment. You may calibrate the line width as a function of the PO2, and the sensitivity range for the probe that you are using is around 1 millimeter of mercury. And one important thing, because these particles are extremely stable, that they are not clear from the tissue, this provide the absolute PO2 with high sensitivity from the same site over a long period of time. That means that if you want to manipulate the oxygen in a tissue, specifically here in a tumor, you have this capability. And looking to the sensitivity to oxygen of different oxygen sensor, I like to compare this different type of probe. If you use a soluble probe, like a per-deuterated nitric oxide or even a trittle, actually the range of change in terms of line width is around 100 milligauss when you go from nitrogen to air, okay? But don't just remind that we are in the tissue between 0 and 7 or 0 and 5, and in tumor 0 and 3 millimeter, 0 and 3% of oxygen. LIPC provides an interesting straight line in terms of relationship, which is quite convenient when you need to have a point effect, or for example, if you go in a tissue with a high PO2, like in the brain, for example. We like very much to use some charcoal where they have a maximal sensitivity in this low range of PO2, which is particularly interesting in tumor oximetry. Other probe like carbon black, that are the ingredients found in the inks, are much more sensitive, but somehow they are too sensitive because you change so much the line width that finally you decrease dramatically the signal-to-noise ratio. And so these probes are not all favorite. So in terms of the sensitivity we discussed, we have a very good probe, and the fact that they are very stable, it allows to monitor the PO2, for example, short-term after injection of the treatment, for example, or over long term. Of course, if you use tumors in mice, generally they are growing quickly, and so over a few days you have the response about the efficacy of the treatment. But if you look to other tissue, for example, we have made in a long-term measurement in muscle, it may take a few months. So now let's talk about manipulation of the tumor oxygenation. And when you want to manipulate the oxygen, it's a little bit like modulation the water level in the bath tube. If you have a bath tube and the faucet is open, that means it delivers water. And the water is moving away through the draining plug. And so you reach at the one moment some kind of steady state between the delivery and the consumption. And so if you want to increase the level, you may increase the delivery, for example, using the oxygen delivery in the case of tumor oxygenation. But another way is not to play on the delivery, but more on the draining plug, and to decrease the oxygen consumption. And so I will provide you a few examples, some historical from the lab and some that are just ongoing for the moment in the lab. Let's start first with modulation of the perfusion in order to change the tumor oxygenation. And actually, our interest for this purpose starts really more than 20 years ago now, where, I'm working in a drug research institute, so we need to pay attention to the efficacy of drugs. And we look first to different classes of vasoactive agents like calcium antagonists, alpha antagonists, potassium channel openers, angiotensin converting enzyme inhibitors, nitric oxide donors, vasodilators, beta blockers, and so on. And for each group, that was 10 mice used, so you can imagine the number of animals that we use in this study. And we found actually that there were a very good candidate, and some of these candidates were further explored later for the effect in terms of radiation sensitivity. So beside these modulators of the, I would say, the action on the vessel, we also use another treatment that was actually the botulinum neurotoxin as a proof of concept. Actually, botulinum neurotoxin is used to treat intractable muscle hyperactivity, and so they react. Actually, we found that they act on the remaining vasoconstrictive vessel that are present in the tumor. You have some kind of mixed vessel, non-reactive, this is the immature vessel, and some remaining active vessel. And actually, we have identified a real window of reoxygenation. And this was actually linked to an increase in terms of perfusion. Here using DCMRI, and here it's just a map of the perfused voxel inside the tumor. But now, if you apply the radiation in this window of reoxygenation, you see that you have a benefit in terms of growth delay. Same thing, because we are playing on the perfusion, you increase the delivery. And for example, if we combine this toxin together with cyclophosphamide, we had a benefit in terms of sensitivity. And just to conclude with this agent acting on the perfusion, I like to show this example of the combination of anti-angiogenic treatment together with radiation and chemotherapy. Over the long term, anti-angiogenic therapy should decrease the perfusion, the oxygenation. But most of you know probably that there was this paradigm published by Rakesh Jain about this possible window of transient normalization of the tumor vasculature, because you prune the most immature vessel at the beginning of the treatment of anti-angiogenic therapy, so you have normalization of the perfusion. And this was suggested to be a possibility for co-administration of radiation or chemotherapy. And actually, why I present this here, it's because this is really the key is to know when to apply the treatment. This is really the key, because using EPR oximetry and using one of the anti-angiogenic agent, thalidomide, we found that there was first a transient increase over days of tumor oxygenation, and then it decreased. Okay. In the control, you see that you remain very hypoxic tumor. But now, if you apply the combination of thalidomide together with radiation therapy, the success of your combination will really depend when you apply this treatment. If you apply the irradiation there or there before the normalization window or after the normalization window, actually we had absolutely no benefit in terms of growth delay. However, if you apply at the appropriate schedule, there was a clear benefit of the combination. And this was true also for the combination with chemo, because actually when looking to the biodynamic contrast enhanced imaging, MRI, we look to some parameters like the K-trans. We found that at this time of optimal oxygenation, this was due to really a better perfusion. And again, if you apply chemo there or there, you have almost no benefit. But if you apply there, you have a real benefit. So this was for example of playing with the delivery. Now, another possibility to alleviate tumor hypoxia is to decrease the oxygen consumption rate by tumor cell. And actually, Segumb in the group of Mark DeWeerst actually published in a mathematical model a long time ago that it was much more efficient to reduce the oxygen consumption rate to achieve a decrease in hypoxic fraction than playing with the oxygen delivery. And so what it means in practice, that means that in practice we can try to play with the electron transport chain from mitochondria. Mitochondria is the powerhouse of the cell. You have all this complex, and it is possible to inhibit some of this complex in order to decrease the oxygen consumption at the end of the electron transport chain just before the production of ATP. We have played a lot over the time with this. I will show some historical and some ongoing results. So one treatment that was really efficient is Trizenox. Trizenox is arsenic trioxide. And actually, arsenic trioxide is used in the treatment of some leukemia and in clinical trial against some solid tumor. Of course, you are using very low dose. That's not the dose that are used by Agatha Christie in our famous books, where when you want to kill the gardener. No, here it's just to in the context of treatment of cancer patient. And actually, arsenic trioxide at non-lethal dose, not cytotoxic dose, is decreasing the oxygen consumption. This can be measured by EPR in vitro in sealed tubes, where you have, if you start with well oxygenated cells, tumor cells, you see that you have a drop in the oxygen environment with the time, and you see that if they are pre-treated with arsenic trioxide, you have a decrease of OCR. In vivo, we had a dramatic increase. That's probably the highest level that we had using pharmacological treatment, with a window of reoxygenation that we observe in several tumor lines. And just to look to the consequence in terms of heterogeneity of response, we use fluorine relaxometry. And so if you look to at the control non-treated, you see you have a very high hypoxic fraction with most voxel between 0 and 10 millimeter of mercury, but you dramatically change the issue when you apply this treatment. And what we observed was really a dramatic benefit in terms of growth delay using this type of treatment, and also in terms of survival. Now, just to give you more stuff about what is ongoing, we have for the moment in the lab an interest for statin. Statin, as you know, are lipid and hypocholesterolemic drugs. They are actually inhibiting the HMG-CoA reductase that is involved in the synthesis of cholesterol. And when you look to the literature, there is some kind of controversy on the use of statin as anti-cancer agent. Some are claiming that there is a benefit of statin, some others no. But one thing that was quite clear from some studies, retrospective analysis showed that there was a benefit of statin in prostate cancer patients that were treated by radiation therapy. This is one point. The second point is that when you look to the literature, statins are known to decrease the oxygen consumption rate in some normal tissue, specifically in muscle. And so our hypothesis was that maybe the effect of statin was observed in this study was due to an effect of statin on the oxygen consumption by tumor cells. And so we look specifically to this effect, looking to the oxygen consumption, and also we were interested by the effect not only on the oxygen consumption by the transport chain, but also on superoxide production. And actually, Donatien Dos, who defended our thesis last month in the lab, made a toolbox where she was able to measure at the same time the oxygen consumption just by looking the line width of a pair deuterated nitroxide and superoxide production from cyclic hydroxylamine transformed into nitroxide. And using appropriate control, we can see the contribution of superoxide to the oxidation of the probe. And this is possible to measure simultaneously because actually we use probe with a nitrogen 14. This gives a traditional 3-line spectrum for nitroxide and the 2-line probes for oxygen measurement. So you have not superimposed spectra and you can make measurement of both parameters together. So she did a pre-screening with the CR's technology, and she found that 2 of the 5 statins that we used were actually working on the oxygen consumption rate, and this was confirmed using X-band EPR oximetry, where you have a dramatic decrease in oxygen consumption rate after treatment with simvastatin or flavastatin. Also, flavastatin dramatically increased the level of superoxide in treated cells. But what we have found also is that using the prostate cancer tumor model, there is, after administration of statin, daily administration of statin, you see that you increase the oxygen after using simvastatin or flavastatin. The level reached in terms of oxygen is not the same, but the behavior is quite the same. And for the moment, the mice have been injected and they are treating with radiation the mice. And so I hope to give you results in a couple of weeks or months. Same thing for another compound that we have tested together with the group of Marseille, Michael Hardy and Olivier Wary in Marseille, synthesized metformin. Metformin is anti-diabetic drug. They target to the mitochondria to have a much larger effect on the, in order to have to get a larger effect on electron transport chain. And indeed, we observed in 2 different prostate cancer cell line. You see this one is more oxidative than this one. The level of oxygen consumption rate is not the same, but actually the compound was active in both type of cell line. Again, we have a window of reoxygenation, and we have included also a group treated with metformin in the ongoing studies. Finally, I would like to show you also another example, a last few example, and the story starts with insulin. Insulin, when you make a slow infusion of insulin, you have a dramatic and prolonged effect on the PO2 in minutes and hours following the administration. And actually, it turned out that, again, this is due to a decrease in oxygen consumption. And actually, looking to what happens, actually, insulin is stimulating the phosphorylation of the endothelial nitric oxide synthase. And because of that, you have a dramatic increase in level production of nitric oxide. And this can be reversed using the compound L-name. And so the increase in the PO2 induced by insulin is actually really well mediated by this effect, because if you inhibit this effect, you inhibit the effect on oxygen level. And in terms of radiation, what we observe is that insulin, together with radiation therapy, was really efficient compared to radiation alone, and even better than carbogen. And I will come to this in a few slides. And actually, in terms of response to radiation, if again you inhibit the phosphorylation of enos, you inhibit the SI effect, and you come back to the something that is quite superimposable to the irradiated alone. So we play a lot with nitric oxide, with actually nitric oxide donor like ethosorbate dinitrate, electric stimulation, and we try to look to the scenario in vivo, looking to the importance of oxygen, but also the importance of nitric oxide. And for that, we measure nitric oxide using spin trapping with MGD iron spin trapping. And what do we observe? And this is quite interesting to show. If you look to the PO2, if you make breath your mice bearing the tumors with carbogen, you see that you have a dramatic increase, at least in this tumor model. And this was the highest level that we achieved. Insulin was quite efficient compared to the control group, but it was lower than carbogen. Now, just look to the factor of response to irradiation. Actually, carbogen was effective compared to the control, but it was less efficient than using insulin. And we anticipate that this was due by an intrinsic role of nitric oxide. Because if you look to nitric oxide produce, it's a really large effect in the tumor. And somehow this is consistent with other work that have been done, especially by the group at NCI, by Murali and John Mitchell, where actually the scenario is that probably nitric oxide is playing by several factors. It contributes to a vasoactive agent, favoring the perfusion. It inhibits oxygen consumption because interaction with cytochrome C in the electron transport chain, but it also has intrinsic radiosensitizing effect. So overall, all these factors contribute to the efficacy of radiation therapy. So this is mainly what I wanted to show you for this effect on treatment. Here I present only two approaches, the vasoactive drug oxygen consumption rate inhibitors, but there are other approaches, irradiation, physical treatment. You have allosteric hemoglobin modifier, anti-cancer treatment themselves may play a role, and of course oxygen carbogen breathing. And of course we are not alone to have worked with this. You have the group in Dartmouth, the group in Chicago, the group at NCI. They've all contribute, Martina, have all contribute to this factor. And if you want to have some kind of database on different ways to play with oxygen, I may suggest this reading of the recent paper in Applied Magnetic Resonance. But in this paper, I also discuss the result and try to compile the result obtained in different tissues, like brain, kidney, liver, heart, skeletal muscle, skin, in the graft. This is also an extremely precious role of EPR oximetry with particulate to make longitudinal studies to see how oxygen is changing depending on the factor that you put in the graph in order to favor the reoxygenation. So my take-home messages is that I think you know and to have convinced you that tumor hypoxia is really a detrimental factor for tumor progression in response to a cytotoxic treatment. That rely very much EPR oximetry, specifically with particulate probe, because this capability to make longitudinal studies and repeat measurement when you want to start with a new pharmacological treatment, knowing really in real time what happens in terms of oxygen is really very important. And so using this way, we have been able to identify a new treatment to alleviate tumor hypoxia and radiosensitized tumor. One aspect that I didn't mention here, but somehow it is a teasing for the next talk in your O2M seminar, because I know that the next speaker will talk about a comparison with other imaging technique. We've worked a lot on this, on DC MRI, bold MRI, T1, T2 star, T2, and also nitroimidazole, for example, using fluorine 18 FASA, for example. And finally, I would like really to acknowledge all this brilliant researcher that I had in my lab. This is really a dream team. This is the list of PhD student and postdoc from the last 25 years. Yes, I'm getting old, and so with that, I thank them and I thank you for your attention.
Great, thank you very much, Bernard, for this very nice presentation. So I'm sure we'll have a lot of questions. So if you want to ask a question, just unmute yourself, or you can also write your question in the chat.
Hal Swartz. So Bernard, one question. First, I must say it was an absolutely brilliant presentation, and I'm extremely proud to have had some association with you. You make me look good, which is hard. But let me do a little challenge and suggest a slight change in terminology. So we have talked about the quantitation of EPR oximetry. And I think we ought to talk about the ability of EPR to look at changes. Because if you take any value with any EPR technique, or indeed any technique, and you say this is the oxygen in the tumor, you are presenting a value which is clearly an average of a wide range. And we're never, ever, with any technique, going to be able to really resolve the heterogeneity in tumors, but it's probably irrelevant. What's really important, which you've demonstrated so beautifully, is that you put something in to decrease oxygen consumption, and you change the oxygen, and you don't know the details of the distribution of the change, but what you have is the really important information that you changed it, or when you changed it. So just a subtle push to people to focus on the ability to look at changes and not to fool ourselves about absolute quantitation.
Yeah, I agree that, of course, when we do mainly spectrometry, so it's an average of the distribution of the oxygen sensor in the tumor. I would say that what we are doing for pharmacological treatment, it's generally sufficient to tackle the optimal window of the change. I would say that if we are thinking a little bit further, and that's why generally we applied, for example, fluorine relaxometry to have an idea of the heterogeneity of the response inside a tumor, and that is obviously EPR oximetry by imaging. It's really interesting in this matter. We have not this capability, so with our Alexis L band is too slow to make anything interesting for that. So I would say there's something that we are not tackling, that if we want to make distribution of dose of irradiation, we are not able to do that. If we want to do cycling hypoxia, I work a lot about this, because this generally occurs in some subtle, a few voxel in part of the tumor, and you see this increasing, and this has been tackled by the group of Mirali, or even also I think in Chicago. We used a dynamic MRI to make this kind of measurement. So I would say everything is in everything. For measuring change that are induced by drug or any other treatment, I think spectrometry is really sufficient. Also, you may play with, as you are doing also in Dartmouth, with several probes and with using a gradient, you may have an idea of this distribution from several sites, what happens in several sites. And if we look, for example, to other applications, for example, in wound healing or in grafts, the ability, for example, to put a few crystals directly in the graft is really extremely interesting, just to see the dynamic change of and the TAR, for example, induced by several factors that you may put in the graph. So yes, this is not absolute, but somehow it's sufficient to change the efficacy of the treatment.
Bernard or Hal, this is Gareth Eaton. What, from your perspective, how rapid a change is it important to measure?
Well, that's a good question. My guess is rapidity is not very important. You're talking about treatments that extend over time. You're talking about dynamic processes, and it's really direction. And I would argue that even those techniques which are purported to give spatial resolution are still reporting averages. And probably the more places you look at, the more information you have, and the more useful it is. But I think we make it too complicated. What we really need are changes and some distribution of the changes and a recognition of reality. Because if you would take any point in a tumor and look at it over time, you would find that the oxygen is changing unless it's in a dead part of the tumor, which is probably not very interesting. So what we can do, and of course, the eventual determination of the value is outcomes. So Bernard not only showed that the theory, but he also showed the outcomes. And that's exactly what we need to do.
Yeah, if I may add also, that's not only a question of spatial resolution. I think we need also, depending on the question, but the temporal resolution is also extremely important when we want to see the effect of a drug. Because as I showed you, some drugs are acting over a very large window timing, but some have very acute effects, okay? And so the ability to be on the same side and without changing anything, to see the change over the time without the need to again inject, for example, a probe to measure, this is really interesting. Otherwise, you need to somehow, that's what we do when we combine with DCMRI or fluorine oximetry. We first identify the time window, and then we know the crucial window where we want to know the spatial heterogeneity of what happens. Okay, so that's something really interesting, and that's, for example, what is extremely difficult to make with other imaging modalities like nitroimidazole. You may have somehow an idea that you have hypoxia, or actually nitroreductase content in the, which, so that means the redox status in the cell, but it's extremely low because you need to infuse your compound and you make your PET imaging 2 hours later on. And so if you have a dynamic change in terms of oxygenation, you are absolutely unable to tackle this, okay? except if you use one population with treatment, one population without treatment, and you try to estimate that you are in the middle. So this is quite one of the interests of this capability to measure with the longitudinal with no limit in time window, I would say. But of course, when you have identified the time window, I think that the fact that you add really at a good timing, appropriate timing, an image of what happens is really a benefit that to put things together.
I think there was a question in the chat. So Tim, do you want to, from Team UBank? Tim, do you want to ask a question yourself, or you want me to?
So what was the insulin work? It was in mice, yes, indeed. We did in 2 different methods. It was a very slow infusion of insulin over time. I have we need to look back to the paper to see exactly the flow. And what was also interesting in preclinical studies, we also show that if you combine insulin together with glucose infusion, actually you have no induction of hypoglycemia. That could be really problematic. But you keep the response in terms of nitric oxide production and the effect on oxygen consumption. So that's the way we use. Possible carbon delivery. Actually, no. What we use for the sensor, the carbon material is put intratumoral. It's intratumoral injection, and generally 1 or 2 days before applying our pharmacological treatment. So it is in the place for.
Sorry, I meant that's supposed to be carbogen. It keeps correcting to carbon.
Carbogen.
So carbogen. So when you say infusion, do you mean systemic infusion, not intratumor delivery, correct?
No, it's a systemic infusion.
Okay, so my point is that you're seeing different benefits of carbogen delivery versus insulin, and is it possible that those 2 things get to those hypoxic regions differently? Because if your carbogen is only going to be likely and able to oxygenate through vessels that are actually functional, and those regions that are not functional, you might not even get carbogen delivered to those regions. Insulin might be different. Insulin might be able to get in there and have an effect in some of those regions where carbogen cannot reach.
Yeah, that's something that we had always in mind. This was done in master thesis, not in PhD thesis, and not in papers, where we try to combine inhibitors of oxygen consumption together with compound playing with the perfusion. So you may act on both aspects, and carbogen, of course, is could be interesting, but I have no definite example where we get really a benefit, because I would say when you look to the curve of the relative radiation sensitivity, when you are over 10 millimeter mercury, it doesn't change anymore. Okay, so I agree with you in terms of the areas that could benefit. Okay, because tumors are so heterogeneous that you may have some resistant areas, and that's why adding imaging at crucial point could be important, just to identify the areas that are not responsive. But so far, even using some crude approach that we have used, we had really a relationship between the effect on oxygen and response, except the case of nitric oxide, where you have additional effect, where it's not only a matter of oxygen.
I have a question, Bernard, too. Actually, two questions. But I love your illustrations, that with the bathtub and with the sauna. Fantastic. That was very cool. So one of my questions is regarding insulin. So you are saying that the effect of insulin is more through nitric oxide, and it's not a change on the metabolic level.
No. You have both. You have that's later on that we found that nitric oxide by itself is likely to have contributed to the radiosensitizing effect, because when we first published the paper, we didn't think about this. We just tried to identify but because historically, my assumption was that we will play a role on perfusion, because we know that if you have insulin infusion, you increase the perfusion in the muscle. Okay, this was, and actually we observed by the CMRI that was the opposite effect. So the only key was the oxygen consumption. We measure ex vivo from cells that were exposed to insulin to show that indeed. And then looking a little bit to possibilities, we identified that this was phosphorylation of enos. And later on, looking back to different results that we obtained with nitric oxide donors, and also, for example, electric stimulation in the muscle where the tumor were implanted, we had always this idea that actually there was something in addition to the oxygen effect, that oxygen was not able to give the whole truth for this treatment. But of course, I'm restricting this message for nitric oxide donor or drugs playing with nitric oxide. For other, for me, it's just an oxygen effect that we observe.
Okay. So would you generalize that actually, manipulating the tumor metabolism is more effective than, trying to deliver a drug through an inefficient vasculature?
I would say you have the model of the group of Mark Durist. And in several cases, not those I listed here, but for example, if I remember our studies with several anti-inflammatory agents, they were glucocorticoids or non-steroidal anti-inflammatory agent. We have worked with both. With this compound, if I remember well, and I think that Mark Durist make an editorial on our paper, saying that actually we had this dramatic effect on oxygen consumption, but no effect or even adverse effect on the perfusion. And so the compensation was good enough to somehow prove the model of SECOM. But I would say that in such a case, there would be a clear input for a combination, as Timothy mentioned, to combine oxygen consumption inhibitor and facilitator of perfusion or oxygen delivery.
Okay. Just a short question. Have you seen any effect on metastasis? I mean, in the PC3 model in nude mice, probably not, but have you done this in any syngeneic mice?
No, that's actually why we have developed this this kind of toolbox to measure nitric oxide and oxygen consumption at the same level, because that maybe that in our university, Pierre Sonvaux,
yes,
we are working together with many common PhD students. And one of his hypotheses is nitric oxide at moderate level may facilitate the metastasis. And that's why we want to somehow to titrate the nitric oxide and the superoxide, superoxide level in the tumor. That just to see, because if you have a massive release of superoxide, you go to apoptosis and cell death. But if you have the moderate level, it seems to stimulate metastasis. And so we are trying in several models for the moment, this is ongoing PhD thesis to see if the ambition is to titrate this, but this is ambitious, but I'm not sure it's maybe science fiction.
No, that's very nice. I mean, even if you discover a little bit, that would be great. Thank you.
Yeah, thank you very much. It was a wonderful talk, Bernard. Thank you so much for
Thank you.
Your presentation, and we all enjoyed the cartoons and also very nice. Yeah, I agree with Hal that probably in the end treatment, what's the outcome is matters, even if we have the absolute number not correct or whatever, in the end outcome matters. So thank you so much, and thank you all for joining, and I hope you'll tune up next month when we'll have another presentation from University of Chicago. Ina Gerstein will be presenting comparison of PET hypoxia measurement with EPR and with DC and CEST, I think she has done. So it will be interesting talk. So hope all will join and have a good rest of the week and rest of the month. See you soon. Bye.
Bye-bye.
Bye.
Thank you. Bye-bye.
Thank you.